one. Hello, I am Dr. Holly Thacker. I am Professor and Director for the Center for Specialized Women's Health at Cleveland Clinic and the Executive Director of Speaking of Women's Health. And I'm happy to be here to talk to you about female sexual dysfunction, hypoactive sexual disorder, desire disorder, and interdisciplinary treatments. Our objectives are to review sexual health and the prevalence of FSD in women, discuss first-in-class therapy, as well as interdisciplinary techniques for hypoactive sexual desire disorder management, and direct physicians and your patients to helpful resources. So sex and sexual health is important to women across the adult life cycle. It's an important component of health as well as emotional and physical intimacy. And certainly physical intimacy is a means to achieve emotional intimacy. And women's health physicians and allied health can certainly help to both optimize pelvic floor health as well as the sexual health of adult females. Now, the biopsychosocial model of the female sexual response is complex. It includes biology, psychology, sociocultural aspects, and obviously interpersonal interactions. Now, in terms of the overlap of diagnoses of female sexual dysfunctions, there is certainly overlap. The most common FSD in women is hypoactive sexual desire disorder. It may or may not be accompanied with arousal disorder or dyspareunia, which is painful sexual activity, as well as orgasmic disorder. And then vaginismus is increased tone of the pelvic floor and the vagina, which can lead to dyspareunia. Now, most sexual function is actually at the brain level, and it appears to be modulated by specific neurotransmitters, several brain structures, and neurohormones. And some of the neurotransmitters are dopamine, serotonin, epinephrine, norepinephrine. There are several structures in the brain that have to do with sexual function. And some of the obvious neurohormones include, of course, estrogen, testosterone, and oxytocin, even endogenous opioids, and phenerones. Now, in terms of female sexual function and psychosocial issues, there's obviously a lot of overlap. Certainly relationship issues, priority, partner, time, distraction, past sexual history is very important, particularly if there's been a negative experience, especially if there's been any painful sexual activity or prior abuse, particularly sexual or emotional abuse. Certainly stress, aging, sexual performance anxiety, and other cultural and religious influences may also play a role. Now, in terms of in the office for busy clinicians, there are a variety of validated tools that you can use to assess female sexual disorders, and you certainly do not need to be a psychiatrist to do this. I list here a number of these tools, and they're referenced. The one that I find most helpful, which is quick and fast, is the Decreased Sexual Desire Screener, DSDS. And it's a brief diagnostic tool that you can use to diagnose hypoactive sexual desire disorder, HSDD. Now, there are some challenges in the differential diagnosis, but during your regular exam and your annual visit, I think to just nonchalantly ask questions and do an exam really helps in that differential diagnosis. You first have to exclude that the cause of the low desire is not due to a certain medical condition, hormonal deficiency, neurologic disorder. You also have to make sure that the sexual dysfunction is not due exclusively to some sort of physiologic effects of a substance, either prescription or illicit drug use. And if there is both hypoactive sexual desire disorder and concomitant sexual dysfunctions, you need to note both. And the diagnosis of HSDD is not made if the low sexual desire is better accompanied for by an axis 1 psychiatric disorder like major depressive disorder, obsessive compulsive disorder, OCD, or post-traumatic stress disorder. However, you can still diagnose HSDD in these patients if the low desire did predate their Axis 1 diagnosis. Now, in terms of drugs and therapies that certainly can affect sexual function, many of the obvious ones are the psychotropic drugs, particularly antipsychotics. SSRIs can certainly impair both libido and the ability to climax. Other drug classes, chemotherapy agents, people are very sick many times getting cancer treatments. Aromatase inhibitors really wipe out cellular estrogen and can have significant effects on sexual function. You know, even histamine blockers, as well as weight loss medicines, immunosuppressants, opioid antagonists, and central alpha adrenergic agonists, just to name some. Now, in terms of the ongoing search for medical treatment, it's been ongoing for a long time. Certainly, hormone therapy has an established role to treat menopausal women with symptoms. There are non-hormonal options such as the estrogen agonist antagonist, ospemifene, which is FDA approved to treat vulvovaginal atrophy or the so-called genital syndrome of menopause. Looking at DHEA locally, which has been recently FDA approved. Testosterone is off-label, but there's been studies on that. There's research on injectable bremelanotide, which is used more as an aphrodisiac. And we've had Flibanserin, first-in-class treatment for hypoactive sexual desire disorder, which has been FDA approved for 2 years now, and I've used it in my practice for 2 years. In fact, I wrote about it in the first book I published in Women's Health, Your Body, Your Hormones, Your Choices 10 years ago. I've done a lot of research on this agent. Now, I do want to touch on anorgasmia, or the diagnosis of difficulty reaching orgasm after ample sexual stimulation, which causes personal distress. And a lot of women and clinicians don't realize that a good % of women don't consistently have orgasms with simple, straight penile vaginal intercourse. Many women need direct clitoral stimulation. And sometimes just mentioning this just nonchalantly as being common really relieves a lot of concern and anxiety for women. Certainly, climaxes can change with age, medical conditions. With age, it can take more stimulation. Medications can certainly affect it. I talk to my patients about the so-called cligiva, you know, the clitoris, the G-spot in the anterior lower part of the vagina near the anterior vaginal wall, as well as the vagina. Some women do get sexual stimulation with breast and nipple stimulation. So you want to ask non-judgmentally about this. Zester lotion is an evening of primrose oil that has been studied in a small trial helping to show improvement in climax. And off-label vaginal DHEA I've prescribed for 10 years, but now as of a few months ago, Intrarosa, which is vaginal DHEA, was FDA approved as a nightly vaginal suppository to treat atrophy and help sexual function in postmenopausal women. Now, I show this over-the-counter agent intensity device, which stimulates the pelvic floor, the stimulation contacts, causing a Kegel. A lot of women don't even know how to do a Kegel exercise, which helps strengthen the pelvic floor. When a woman climaxes, it's those muscles that contract. Direct clitoral vibration can help, and so for patients with lax pelvic tone, incontinence, or difficulty with climax who have normal hormones and normal desire, many times I will recommend this agent. Some women with low desire also have impairments in climax, so you want to kind of look at the whole picture. Now, getting to the first-in-class therapy, Flibanserin, which is FDA approved for premenopausal women. We've had it now for 2 years. I encourage clinicians who see women to get certified. It's pretty simple. You have to answer 4 questions online. It's one single dose, 100 milligrams at night. You do need to be certified to prescribe it, and the pharmacist has to be certified to dispense it simply in order to educate the patient that alcohol use is not recommended because that can raise the level of Flibanserin, which could lead to hypotension, syncope, headache. And it's very similar. The side effects are even less than similar other CNS class of medications. So if you're comfortable prescribing SSRIs, SNRIs, and medicines that affect dopamine like Wellbutrin, I think this should be pretty easy. We do tell patients to take it at night in case they do get sedated. They'll be asleep. It is not an aphrodisiac. It does need to be taken nightly, and you know within eight weeks or so if there's going to be an effect. If there is an effect, great, you continue it, and the women know when they're improved, and they're very happy to continue. And for those people who it does not work, simply you stop. Now, there is evidence that it works in postmenopausal women. The Snowdrop trial showed that, but currently it is not FDA approved in the postmenopausal 56 age and older group of women. Now, in terms of the 4 questions that you need to answer correctly to get certified online, why is alcohol contraindicated with Flibanserin? A, hepatotoxicity, B, teratogenicity, C, hypotension, or D, hypersensitivity. So say what you think the answer is, and as I mentioned, the side effect of hypotension, that is the reason. It is metabolized through the liver, and if patients are on lots of other medications that go through that cytochrome P450 enzyme, you could have higher levels and lower blood pressure. So what is the purpose of having a Flibanserin REM patient-provider agreement? A, for MDs to counsel, B, for charting, C, for safety, D, for the pharmacist to counsel, or E, all of the above. So E is all of the above is the answer. It's for all of those reasons. How often must pharmacists counsel patients about the need to avoid alcohol while on the medicine? A, never, B, only if the patient asks, C, just with the first script, or D, with every prescription. The answer is D, with every prescription. And finally, what's the primary counseling message for the patient? A, don't drink alcohol until you know how it's going to affect you. B, limit your alcohol while taking Flibanserin. C, do not drink any alcohol. And D, do not drink alcohol at night when you're taking your Flibanserin. So the correct answer is C. We're to instruct our patients not to drink alcohol because it can raise the level. Now, in the trials, about 60% of women did imbibe social alcohol. So I have patients sign the form saying that they're not planning to drink alcohol, and I think if they're serious enough and concerned and distressed enough by the HSDD diagnosis, most of the patients will do that. And for people who cannot give up alcohol for a certain amount of time, certainly I think you need to then investigate if they have, alcohol or substance problems. So what are some off-label therapies and other future therapies or other treatments we have? Well, bupropion, which is, goes by the name Zydan or Wellbutrin and other names, has been used in patients off-label who have trouble climaxing after arousal, especially for patients that are on the SSRIs, the selective serotonin reuptake inhibitors. Now, PDE5 inhibitors like sildenafil or tadalafil, or can be used in women actually off-label, even though they're only FDA approved in men, in women specifically who have trouble climaxing on SSRIs and have to stay on SSRIs. It also has been used and studied in women that have vasculogenic arousal problems, like diabetes and multiple sclerosis. Sometimes I'll have patients come in who said that they used their husband's Viagra to help them climax. That's a very small group of people. Now, 1% vaginal DHEA in a vaginal ring is still under study, but the suppository in the 0.5% nightly dose of vaginal DHEA is FDA approved for nightly use for postmenopausal women with genital syndrome of menopause or atrophy who have some sexual dysfunction. And I mentioned the injectable bremelanotide, but it is by injection. And then there's combinations of testosterone with PDE5 inhibitors. So in conclusion, I always like to show this slide because I think humor goes a long way, just with our patients and with practice in our lives. And here's this husband saying, "Good Lord, Ethel, you can't appear in public like that." And of course, they look alike. So we have to be kind of accepting of our patients and non-judgmental and be able to direct them to helpful resources. And my nonprofit website, Speaking of Women's Health, www.speakingofwomenshealth.com, has thousands of pages of free, non-branded health information on lots of women's health topics, including a free treatment guidebook on female sexual dysfunction, menopause, many topics, lots of information on pelvic floor function. And so we use this as a resource, and it's free. Anyone with an internet connection can have access to that. So I thank you for your attention, and it's very important to address these needs in your patients. It's a common underdiagnosed treatment that does cause distress for the woman, many times the relationship as well, and being able to evaluate it, assess it pretty simply and directly for many of the patients. Maybe not all of the patients, maybe some of your patients may need to be referred to sex therapist or specialist, but the vast majority of patients that you see in your regular practice, you can help. But you do need to know the differential diagnosis. You need to look for contributing causes, direct the patient to resources. And if you are going to prescribe the first-in-class therapy, Flibanserin, 100 milligrams nightly for the women who are premenopausal and are not instructed to not drink alcohol, you do need to go online and get certified and answer those 4 questions. And it's very satisfying to treat patients holistically, and they're very, very grateful. And when you put them at ease and make them comfortable to talk about things, it does not have to be a very long office visit. So I wish you good luck in treating this. It's exciting, with the pun intended, this therapy and the options that are coming down the pipeline. So thank you very much.
Okay, go ahead.
Hypoactive Sexual Desire Disorder.